Hello, I'm Dr. Jeffrey Cook. I'm going to present to you regarding SFA vessel preparation as well as a quick case to illustrate. I'm coming to you out of Quincy, Illinois. I'm an interventional cardiologist. I also worked with Dr. Skowronski for several years in my prior position. What is vessel preparation? This can be difficult to define from one operator to the next. Generally, you are changing the arterial compliance in some way prior to definitive therapy, such as DEB or stent. You're trying to facilitate full expansion of the lesion without complications. Certainly, high-level randomized evidence is thought to be lacking, although there are many practical advantages. Reasons to prepare fempop vessels. First of all, dissection is reported to occur 50 to 84% of the time in SFA after POBA. This may be underestimated in longer, more complex, and occluded vessels that we are treating with PTA and atherectomy. The degree of dissection is a major determinant of acute thrombosis and delayed vessel closure. Vessel prep is intended to maximize the lumen, reduce barotrauma, reduce recoil, and reduce dissection. In the DEB era, it is also used to facilitate drug delivery. Note in the Lutonix registry, there was a 35% bailout stent rate, and in the impact registry, there was a 40% bailout stent rate. Options for vessel prep to date have included laser atherectomy, directional atherectomy, orbital, etc. Why not just stent after the fact? Stenting is less favorable in SFA lesions due to the hostile nature of the vessel. Results are increasingly better with stenting, but historically there has been up to 70% in-stent restenosis at 1 year. Stenting limits future treatment options, and certainly there are also no stent zones across the joint. Long segments of stenting typically to be avoided as restenosis and fracture increases as the length of stent increases. New devices have shown better outcomes. The Sapira device reports 86% primary patency at 1 year, and the LifeStent 81% patency at 1 year. At the very least, you would like to try to avoid multiple stents to avoid added cost and risk of in-stent restenosis. Spot stenting has gained favor. Atherectomy has been around for some time. It can reduce the need for follow-up stenting and can have excellent immediate results with no metal left behind. In the definitive AR trial, which compared atherectomy and DEB versus DEB alone, severe dissection was seen less frequently after atherectomy, 2.1 versus 18.5%, with less bailout stenting. There is also the theoretical advantage of improved delivery of the drug to the blood vessel wall after atherectomy. In the definitive AR trial, 82% patency was seen at 1 year. Longer lesions and occlusions did statistically better with atherectomy before DEB. Drawbacks of atherectomy include requirement for multiple insertions and removal of the device, time, potential for deeper vessel injury, and the potential for distal embolization requiring EPD. Cutting balloon or scoring balloon angioplasty, certainly very user-friendly, as simple to do as POBA. In a retrospective study by Hong et al., scoring balloon reduced severe dissection compared with POBA, 40 versus 75%, and reduced stent implantation, 27 versus 55%. There was no difference in 1 year in outcomes for target lesion revascularization. However, that is good, as you are basically seeing equivalent outcomes with less stenting necessary after using a scoring balloon. The Flex scoring catheter is a novel device, non-balloon-based scoring device designed to maximize PTA results and reduce the need for high-pressure ballooning. It is simple to use, it is 6 French compatible, and very easily deliverable. One size fits all. It is targeted for the fempop vessels. It has 3 blades that are unsheathed distal to the lesion, and pullback is performed. The blades are very flexible across the contour of the vessel, applying 1 atmosphere of low pressure. The concept is longitudinal scoring of the lesion, creating micro incisions. There is no basket to fill, and it only needs to be inserted once, although multiple passes can be done quickly. This is a cartoon demonstrating the presence of micro incisions after the Flex device. This is an OCT image after a Flex device was applied, showing that the depth of the incision is basically equivalent to the cutter height. Data regarding the Flex device: significantly less dissection by IVUS compared with atherectomy. Real-world case series showed 0 flow-limiting dissection or perforation in 350 cases, with the average length treated 130 millimeters, and the average balloon atmosphere only 4.4 atmospheres. Another study using Flex before DEB showed only 4% of patients with a linear dissection no flow-limiting dissections, and no stents required in 263 patients. Efficacy data: Flex with DEB in 65 patients, required 16% bailout stenting, and freedom from TLR at 1 year was 93%. Bench data also exists, demonstrating improved adhesion of anti-restenotic drug to the vessel, which is 21-fold. This was done in a porcine model. Now a case example. This is a 61-year-old smoker with a history of laryngeal cancer, COPD, and alcoholism. He has no known cardiac disease, and his previous cardiac testing has been unremarkable. He was referred to me by podiatry with resting foot pain and a punctate wound of his left heel after stepping on a nail. He is nonverbal due to presence of a tracheostomy, but communicates by writing in a notebook. He has a wound refractory to local wound cares at 8 weeks, hence would be considered non-healing, Rutherford 5. Doppler ABI was performed showing a left-sided ABI value of 0.6 and a right-sided ABI value of 0.14. Exam revealed a thin-stature gentleman with 1+ femoral pulses and non-palpable popliteal and distal pulses with a dressed wound of his left heel. Inflow imaging revealed patent aortic bifurcation and patent common iliacs. He has significant bilateral external iliac disease with a gradient-provoking lesion on the left. His SFA was shown to be occluded mid-vessel. There was an extensive collateral network present, reconstituting at the popliteal. The SFA contour appears to be significantly calcified. Additionally, there was sequential severe to critical disease present of the popliteal. Below the knee, we see 3-vessel runoff with several zones of visually significant disease. We were able to cross the lesion with a Viance catheter backloaded with a Grand Slam wire. I prepped the distal SFA with a flex device for 3 passes. I then performed drug-eluting ballooning of the SFA with a 5x100 impact balloon. I followed this by applying the flex device at the popliteal. You can see the movement of the tines basically as I pull back, as it moves with the contour of the vessel. We then applied a 4x80 impact balloon to the popliteal. I performed spot stenting of the SFA to address recoil. However, the results of the popliteal were excellent, with no need for stenting. You can see restoration of brisk flow below the knee. And the patient is pain-free with a healed wound 6 months later. Thank you from Quincy, Illinois. Enjoy the rest of the presentations.